Okay, I'm recording it here. Okay, welcome. Here we are to another episode of HP's 5 Minutes with a Member. And today we're going to be discussing suicide prevention. And in fact, we just finished what's known as Suicide Prevention Month. We hope to focus on a key concern in the community at this time. That's typically what we do with HPs. So as an introduction again, I will describe for all of us, including our audience, what HP is about. Basically, it's an online idea group, and we hope to understand better the social determinants of health. As a practicing primary care physician, it's so challenging to get to real wellness in the office. And I've come to learn over the course of my career that really the community has to be well in terms of health in that community. And for the community to be well needs at least two things. The community has to feel empowered to share their voice about the health concerns that they're facing. And secondly, the professionals in the community who are lucky to serve have to have an approach of alliance, or the common word that people using today is allyship. That is how we're able to not advocate, but how we're able to share our expertise and the power that professionals have to really help the community find their voice. And in this process of allyship, I have found that only capital letters and underscored, only collaborative and interdisciplinary approaches really do solve community problems. So that's basically what HPeace is about. We're lucky to have a community member today with us, Everett Sivils from Salinas and the Monterey Peninsula. And as I said, our topic today will be Suicide Prevention Month. It's September, so I guess we're still in September until tomorrow. We'll call this September 32nd or something. And to put the problem or the challenge in perspective is, as you can see, I understand that worldwide, the WHO says that if my numbers are correct, there are 800,000 suicide deaths per year worldwide. And the last data in America shows that the number is 48,000, and I believe that year was 2018, and the number has been increasing. The highest rate is found in men. And just to give you an idea of the number, it's 20 men for 100,000 population. And nationwide in America, the number is about 14 people per 100,000 population commit suicide. That's how you get to that 48,000 number. And then very concerning is what's happening in the adolescent and young adult population. That seems to be the highest rate of rise is happening in that population. And as of 2018, the number was around 14 and a half, between 14 and 15 young people between age 15 and 24 committing suicide. Out of my chart says 10,000, but really it's 100,000. So it's the same denominator each time. And then what brought this topic to my attention this year in September was there have been an unfortunate spate of suicides at Soledad CTF this year, which is where I work. And in the last calendar year, we've had 4 suicides. The population is about 4,500 to 5,000 men, and we've had 4. The expected number of suicides, it's terrible to talk in these terms, but data is so important to programs nowadays, to fostering good programs. In 2017, I believe, the correctional system in California had 39 suicides among 35 prisons. So each prison typically has about one suicide a year. But as I said, something is changing. And in the last year, we've had 4 in Soledad. I've also heard that in the military system as well, the suicide rate is increasing. So I just wanted to set a context and for today's discussion, and then I'll get back. Does anyone, would anyone, Judy, would you like to, what do you think about those numbers from a bigger picture, from not just the individual and what happens in your office, but what do you think about those numbers? What's been your experience in Pennsylvania with suicide?
I think those numbers are pretty accurate. Locally, what we've seen in our hospital, mostly in our emergency room, is we've had a lot of, I would say, middle-aged persons, males, sometimes Hispanic, sometimes white, all different races, coming in with drug overdoses. And so that's kind of the also encountered this experience. They seem to be the younger population, maybe like in their 20s or below. We only admit 18 and up on that unit, but it just seems as if we are called sometimes as a chaplain to minister to those kind of situations if they've attempted or if they've succeeded, and that can be very traumatic and difficult for the family members. For those who didn't succeed, often, they pull in a lot of supports from the behavioral health unit and also from the community at times. So that's kind of what we see here in Pennsylvania.
What about, I lost connection briefly, but did you speak to at all the youth and young adult perspective in your community?
Well, Amish and Mennonite community here. So I can't say that we've had any suicides committed among them in the 5 years I've been here, but we do see them coming in for other behavioral health conditions where they may need support from the chaplain. So most of them pretty tied well to their communities, and it's a very tight-knit community. We do have 2 staff persons who work with that community, especially Marianne Robbins and also Lydia Nolt. And Lydia is from that community, so she's very sensitive and aware of what some of the practices are within that community. So there was an incident a long time ago, but that was a shooting that happened in the schools. You might have heard of it. But recently, I think the emphasis has been on helping to educate this population about COVID-19, given that they don't, use electronic means of communication. So, those 2 members I mentioned from the playing community go out and do education and try to be a support if any of that community is hospitalized for COVID. But, that's kind of getting off the topic. But,
Well,
in terms of, I don't know if I've seen some youth come through with that Narcan, like people give them Narcan when they're coming in, and so they've survived that because of the Narcan. I probably am not pronouncing that right. So we might call to go up on the ICU after they've come through the emergency room and gone to the ICU, and the family is there, and we give support to the family as they're, hoping for the recovery of the person who attempted the suicide.
yeah, you bring up many good points in your little comments there, including the relationship between depression, suicide, and substance abuse. So that's something that hopefully we'll be able to touch on later.
Mm.
So anyway, without further ado, I'd like to introduce our guest, who is Mr. Everett Sivils. Hope I'm pronouncing it correctly.
Yes.
And he's a community member, as I mentioned before, from some time. for some time, and I understand he works for the Department of Social Services and perhaps the Monterey County Office of Education as well.
Well,
But
yeah, I work for Monterey County Office of Education, but the organization that I'm with is under the umbrella of Department of Social Services, which is the Community Action Partnership of Monterey County.
okay, and is that a volunteer position at the Community Action Partnership, or is that part of your work as well?
No, it's a volunteer appointed position by the supervisor of Monterey County.
Okay, very
So I
good.
represent our District 2 here in Salinas, California. So I'm active politically as well.
And which district is that?
District 2.
And Judy won't get this because she's not here, but what area in Salinas is that?
It covers from the area of where Costco, which is the 93907 area code, down to Aromas and Castroville.
Okay.
So I have quite a big area that also extends closely to, going more toward the east side as well.
Okay, and that's supervisorial district?
Yes, it is.
So that's Supervisor John Phillips.
Correct.
Okay, very good. Very nice man. I've worked with him in the past, and I know he does a lot for the youth of that district.
Yes, he does.
And the area. I believe he has a center. I believe he's responsible for a youth center up in Prunedale, maybe.
Yes, the Rancello Cielo Center.
Okay, very good. So that's a nice opportunity to serve.
Absolutely.
So that was my first question was, what do you do here in town? And my next question in the 5 questions format is, what is the topic you'd like to share with us here, Judy and myself, and with the HP's audience who will be seeing this later?
Well, you laid out the topic earlier in your conversation, and it's definitely about suicide prevention. Unfortunately for myself and my wife and I, we have experienced that with our daughter.
Sorry.
And so I would definitely like to be able to share whatever knowledge that I have gained in the midst of this pain. As your sister said, it definitely disrupts the family. It is not so much disrupting the family with people around. It's worse when no one is around, because you have to deal with it and be proactive.
Mm-hmm. Yeah, and certainly part of when you mention when no one is around, what it makes, first, I'm sorry to hear about that tremendous loss to your family and yourselves, your wife and yourself. When you mentioned when no one is around, the first thing I thought of was the stigma of mental illness. And
Right.
Physically, there may be no one around, but also I think one might feel that there's no one that would understand, or there's no one I can talk to about this, because there's always been a tremendous sense of what about the stigma? Can't even put the right words on it. And the stigma may come from societal expectations. It may come from cultural or religious expectations about, people just have to bear up. There's really no such thing as mental illness. I mean, that's what came to my mind when you mentioned being alone.
Yeah, no, I think you're correct in that sense. For my wife and I, that has never been a concern for us. With
Excellent.
our daughter, it was a rapid decline. Before we can actually get our heads around what we were witnessing within we're talking about a couple of weeks, really, literally, span of time from going through hospitalization from May the 5th to May the 8th, to waiting for next week to speak to follow up with a psychiatrist, to talk about the day program that was, in the Monterey County area. Um, to a couple of days later, my daughter was gone.
Oh. Mhm.
It was really fast, but my wife and I, as well as my daughter, we have always approached things from a realistic side of things. Is if you can do something about it, then you do it. And by
Mhm.
us being a close family, we was definitely ready to work on the next chapter from what we had witnessed. But for whatever reason, that just didn't work out. So, we never was concerned about any labels whatsoever. But I
Okay.
do remember my daughter that morning as we were talking. Um, she was concerned about it. She was a child who never liked taking medicine whatsoever, but she was prescribed a low dosage of Seroquel, and she was being treated for anxiety and insomnia. So, and she had a PRN as well, same dosage. But it's really just to help her sleep at night because she had stated during, her hospital stay, one of the reasons is that she hadn't been sleeping. Now that I
Mhm.
know, which is a
Mhm.
telltale sign of something's going on. But, by her being a young adult and was the only child, it was common for us to be sleeping thinking she sleep.
Right.
We didn't have any other lights to bring things out. Um, but you know,
Yeah, we'll thank you for sharing. We'll get to the warning signs later, but
okay,
but especially with young people, there are so many physiologic changes happening anyway. you know,
yes,
they
yes, yes,
probably do need more sleep, you know. And
correct.
I remember we have three children, and I remember, and we're both in the healthcare field too, my wife and I, and I remember trying to normalize in my mind some of the behaviors we were seeing. I was trying to rationalize it from my training as a physician that,
Correct,
well, their body is growing very rapidly.
correct,
So,
correct.
so I guess what I'm getting at is the warning signs are key, but it's still tremendously challenging, especially
And
in that youth population.
and you're absolutely right. She was a young adult, but you're absolutely right because she was the only child. I did exactly what you did via my friends and neighborhood kids who still live at home with their parents being young adults. Because
Hmm.
that's all I had to compare it to. I didn't have any other kids in the house to say, okay, well, this is something that stands out or something that's different. But everything was sort of normalized
Right.
because I can rationalize it away. Like, okay, this is what this is. My friend's son is doing the same thing, you
Yeah.
know. But that is tremendously uh, a big awareness if
Mm.
you can capture that.
Right. So, what is your daughter's name?
My daughter's name is Dominique Sivils.
So yeah, Dominique was very fortunate to have you and your wife as supports for her because of your knowledge base and including your clinical knowledge base. But you and I both know, especially with the work you do, there are so many families that don't have
Right,
that. There are families that have tremendous barriers, like cultural barriers to getting care. It's not an option to have behavioral health illness,
correct.
the language barrier, which is getting more and more dense. So I would just like to emphasize that what a great set of resources Dominique had, and it's still this challenging problem.
You
Um,
know,
mhm.
um,
And I would
just
like to echo that, and also say you have my condolences about your daughter. I was thinking
thank
as
you.
we're talking, you're welcome, that we find that often a lot of young people come into the emergency room and they're in the behavioral health section of the emergency room, and they have a lot of different things going on, as you've mentioned. But one of the challenges that we found in our hospital is that, which made me think when you were talking about the delay between when she was in hospital and able to see her therapist, that often the resources that are available to respond to the immediate need sometimes are delayed. So we see that in placing young people in behavioral health placements, because we have a Phil Haven, which is our long-term facility.
Right.
And sometimes the people have to stay in the hospital until they can get released to a placement. And I think that's kind of harmful because often we can give them care in the emergency room
Yeah.
and see a behavioral health technician and a therapist and probably get prescribed medication from the psychiatrist. But I think that this population has to be closely watched.
Mhm.
And the other needs that are in the emergency room, they're pulled in a lot of different directions, the healthcare team. So I kind of think that that's a problem, probably not just here in Pennsylvania, it's probably in other places as well. And I'm not sure how it can be solved, but I just wish that the access to the treatment that is needed would be more immediate than having to wait, to be able to see someone.
The ironic thing about here in California is that my daughter had private insurance. Now, by her having private insurance, after the 72-hour hold, she was able to, come home. But in retrospect, if she didn't have private insurance, she would have been seen and she would have been provided all the services and they would have kept her in the hospital and all those things. So by having private insurance, it worked against her.
Mm-hmm.
And like I said, my wife been in the medical field and she has expressed that many times over. That's the one thing that if can be changed, that should be it. Because she had private insurance,
Yeah.
she had to wait.
Mm-hmm.
She was able to be released from the hospital. But if she would have had, non-private insurance, she would have stayed.
So yeah, you're getting into that whole matter about insurance and all the things the administration of the insurance company has to do to ultimately make sure, maybe this is where you're going, to ultimately make sure that they keep their costs down and they keep
Correct.
their premiums down for the population they serve. And
Correct.
yeah,
Yes.
yeah,
That's unfortunate.
that's
Yes.
And
oh,
again, our situation is sort of unique because it was so rapid.
yeah.
Like I said, when we were, at least my wife and I, when we became aware something is not right, was really May the 3rd when my daughter came to us and she asked, "How could I get out of this fake world back into the real world with you two?" And May the 3rd, then May the 5th, of course, the bad delusions, which led to hospitalization.
Yeah.
From May the 5th to the 8th, coming home. And then on the following week, the 15th, seeing her psychiatrist. And then May the 21st, my daughter was deceased.
Oh, wow. Let me, there's so much in that story there. Let me show this slide for a minute to organize for myself and my audience kind of what we're describing and solutions, and then we'll get back to your 5 questions. So I'm going to try to share the screen again with my PowerPoint. So yeah, when we're trying to solve problems at the community level, I like to keep this model in mind, called the social ecological model. And at the beginning of it, at the base of it, is what's happening with the individual, the health conditions that the individual has, the behavioral health conditions the individual might have. The next ring is called the interpersonal processes, which is family and peer support, it was excellent in Dominique's case. It was excellent and solid and thorough and full. The ring outside, this is where it starts to get interesting. And this is where your discussion reminded me of this. What are the institutional factors about mental health and youth mental and teen mental health in our community? And there is no pediatric psychiatric hospital in Monterey County. There will be soon, but at this time and historically, there has not been. And then finally, kind of that's involved with the community factors. And then finally, the outer layer is the level of policy and laws. And in what you were saying, Eric, you were making a plea that we need legal and legislative, we probably need legal and legislative change about healthcare financing around mental health to get at this quirky, strange problem that your daughter was in, about having a private insurance and still maybe not putting challenges on the family. We think that having insurance is a sign of, oh, everything's okay, things are going to work out. But it sounds like in this particular case that wasn't, and it would be great if there was more uniformity in coverage and management of disease, rather than hopscotching it with, oh, which insurance do you have? Oh, that one only allows a 48-hour stay. Now you've got to see an outpatient provider.
Right.
So as
Yeah, because
Go ahead.
No, go ahead. No, we definitely had to wait for, even when she was admitted, for the approval, like you said, for the 72-hour hold and the approval for the next step and the approval for the next step, which was fine as far as having the approval and having the coverage, but it was the time. And we know that time is of the essence when you're dealing with the potential of suicide, which was never a red flag for my wife and I. It just never even, it just wasn't there.
So I'm going to put a placeholder for you and I to circle back with it sometime. And you maybe already know, you maybe already know some of the legislative people and the advocacy people that could get a change about insurance coverage done, but that's just a placeholder check we'll come back to.
Yes, I had a question. I know here in our emergency room, and maybe this is for patients who aren't competent, but they do have a legal means to institutionalize someone. They call it a 302. Used to be called pink paper, but I think that has to be a person who's really psychotic or severely, indicates they're going to harm themselves. So I just wonder if there's something similar, like when you were in the emergency room or at the hospital, did they do like a screening around suicide assessment, or if she had a plan, or, did anyone in her admission evaluate, where she was at? I'm just curious.
No, they didn't. No, they did not, because my daughter, that was her first incident, in a sense. She never had a history. And so that sort of worked against her as well. This is just, when I said it was sort of like a magical thing, it just happened. And everything was really, like I said, it was fast. It was really, from May the 3rd, when we got the question, to my wife and I planning, next steps, what we saw from May the 4th, when she had or May the 5th, early that morning, when she thought, something was in her room and she was terrified. And I remember as a dad, I've never seen that look on her face except for when she was a child, until later that morning, we called the ambulance, because of what we saw as well. And it just went really quick, and she's never had anything like that. So we were just as stunned as she was as an individual going through it. And my daughter was, she's very sensitive about the stigma. And like I was saying earlier, that morning, she had mentioned that, because when she was in the hospital, it was hard for them to put a diagnosis to say whether it was schizophrenia or bipolar. But I remember her psychiatrist said in order for him to prescribe the medication, he's just going to call it bipolar. The treatment would be the same, whether it was schizophrenia or not. And, and my daughter was a psychology major. So she was aware of, the stigmas and the medication, which, my daughter never liked to take in the first place, but she was doing that. But she mentioned that she didn't like the label. Right. And that was the last conversation that we had, because I was researching the, again, the effects of Seroquel and talking about the positivity of what I found in blogs and this, that, and other. But it didn't matter with my daughter, it goes back to the stigma,
Yeah, the stigma is large, even the stigma that we place upon ourselves.
Yes.
The other thing, Mr. Sivils or Everett, is in terms of we talk so much about evidence-based medicine. I'm trying to address, if you're doing the intrapersonal or interpersonal care, you're lucky, that is, you're lucky enough to have a healthcare provider. We talk a lot about evidence-based medicine now. My review of the evidence-based medicine for suicide is that evidence is really limited by a lack of studies. So
Correct.
in
Correct.
terms of what works, in terms of behavior therapy, say, there's just scant few studies about it. There are
Correct.
some things, if you're lucky to get to a provider, things like dialectic therapy, they say, shows good evidence is working. Cognitive therapy for suicide prevention, that shows good success, but still there aren't a lot of studies. And then when you jump over into the pharmaceuticals, then all of a sudden the stigma comes back. And then another factor is the companies, the drug companies, and how quickly they get a drug to serve a population, and
Right.
was the correct scrutiny done. So my whole point is that the intrapersonal and interpersonal, or in particular, those solutions may not be solidly evidence-based, which is why,
Absolutely.
which is why the community level about the warning, understanding the warning signs, that word gets out about the warning signs, that is so important, so
Yes.
that people can pick up on when someone needs help.
And we definitely need, one of the big things too that definitely need to be distinguished is the type of personnel or person who is committing suicide. You have those one who are actually calling out for help, but then you have those other ones that are just gonna do it. There's no call out for help. And my daughter fell in that category. Like I said, there was no major like warning signs for my wife and I to have red flags and say, okay, she needs some attention, she needs this and this and this. That was not the case, you know.
It was not a textbook.
Good point.
No, it was not. It was not.
Yes. I'm sure you and your wife did everything you could for her, you know, like from hearing you talk. And that's true. What do we do with this population who doesn't give you any signs or warning? I know in our hospital, or in Pennsylvania as well, we've had some young people, high school age, who've committed suicide. And it seems as if within the school system, they've kind of rallied together. They've brought in crisis counselors for those students who were behind, so that they could get a sense of how this student population was dealing with these young people who committed suicide. Because I think in our thinking, we think, and this is probably a little biased, but we think a young person doesn't really seem they would have been so depressed that they would want to kill themselves. And I think that's how most of us, probably baby boomers or older generations, think. So we don't really think about this population, or even to have mental health or psychiatric conditions. We kind of think, you know, but then we look at the world in which we live and all the things that are happening. You know, this is not the same society that we lived in when we were younger.
That's correct. And,
You know,
and one of the things that my wives have said, is suicide is contagious. And I say that because after my daughter had passed, I learned that two of her friends had passed as well. One of her friends that she graduated with passed on May the 8th from suicide. And on May the 10th, you know, one of her childhood close friends who spent time in our house with our family passed away on May the 10th by suicide. And the ironic thing is that for the second young lady, her funeral services was starting on May the 21st at 11 a.m. And May the 21st is when my daughter met her demise as well. Now, do I know for a fact that there are linked, or there's something that's there? I don't. But given the circumstances and the way my daughter had to found out the information about her friends, with the beautician who did my daughter's hair, her sons, they all went to school together, and it was also in the same community. So that was the talk of the town. And mind you, my daughter had just came out of the hospital herself, you know. So we don't know but it could be, something that's there, because when you have a fragile mind, it doesn't take much.
Yeah, so
That's
that
a good
rem
point in
yeah,
that these were friends, that she had
right,
lost recently. So
Right,
it could have been an impact on her as well,
right,
you know.
so
absolutely.
that I'd like to talk about that for a minute and then get back onto the five questions for Everett. But
Yes.
what I've become aware of recently is the whole idea about screening for depression. And many of those are done in the offices. Many systems now are recognizing how much untreated behavioral health disease is out there. And so a variety of screens are developing in the office that someone other than the provider can do, that the medical assistant can do, or the LVN can do as they're preparing the patient. There are screens for anxiety. There are screens for depression, and the famous one is called the PHQ-9, which has been abbreviated into PHQ-2. And these are validated screens that explore the chance of depression. But again, in order to even get these screens, you have to be lucky enough to get into the office. So in the bigger picture, in the bigger of those rings, are there community screens? Are there things that we can do with our friends or be aware of in our friends to make people aware that maybe they're going down the wrong path? And in my reading, I've come across something called Beck's Triad. Judy, have you heard about, or Everett, have you heard about Beck's Triad yet?
No,
I
but I
heard
will read
about
about it
Bex.
later.
Go
Yes.
ahead, Judy, what were you saying?
No, I just said I heard the name Beck, but I don't know if it was in a different context.
Well,
But
Beck is,
that there are depression screening scales that
right.
are used in various settings.
So that's true. There is a Beck Depression Index. And he says that there are three key elements that we need to be aware of. And he refers to these as Beck's Triad. And they are the self-esteem of the individual, right? And these are really personal things, right? The self-esteem. Number two is the societal context of what's going on. And at this moment in time, our societal context is really chaotic. And it's potential that the worst of the societal context is the effect of media and social media. And then the third part of Beck's triad is hope for the future. And he suggests that if these three things aren't positive, then that increases one's depression risk and potentially suicidality risk. And what made me think of that, Everett, is your wife's comment that there's something contagious about this. And yes, the data is not here yet about media and social media effect on depression and suicidality. But I do think it's important. Your wife's comment is very key and crucial, right? If all of a sudden depression or even worse, suicidality is considered acceptable or a norm, the mind that's delicate at that moment, it could potentially light a switch.
Right. And I think that switch was lit on May the 17th when she went to the beautician area,
Mm-hmm.
and somehow, some way, just whether it was there in the shop or outside, it was in that community. So to me, my daughter had to have found out. It's like, I haven't seen you in a long time, and the first thing you're going to let me know if we catch up, especially somebody we grew up with, you're going to mention, well, this person just passed away.
Mm-hmm.
It's just a natural human relationship that it happens.
Right.
And
So,
and
mm-hmm.
So go ahead.
So in terms of usefulness of this Beck's triad, I think that it's something that people need to be aware of, and mental health well-being for young people is so important, and the way we react with them, the more positive we can be, the better, to build people up. And this gets back to what Judy was saying earlier about the generational changes, we grew up in a completely different context. The world was,
Correct.
the world was, you know, there were issues in the 1950s, no doubt about it. But in the 1960s and 70s, or 60s anyway, there was a hopefulness. There was the idea
Right.
that the world was opening to people. Women were getting rights. People of color were getting rights, right? And there was a hope. That's not, I don't think that's there today. Uh, so when we are interacting with young people, the more we can do to be positive and communicate instead of a no, you're wrong first, but oh yeah, that's interesting. Tell me more about that. So more inquisitive with young people, and in general more positive. If you notice the way young people talk to each other, they are so positive with
Right.
each other. And that's something different than we had when we were growing up, you know? And then in terms of the context about the media and social media, limiting media to the degree we can, or teaching our young people media literacy, like what's a good website, querying them about is Twitter or is TikTok, is it as good for you as you think it is? You know, throwing those kind of thoughts in their mind.
Well, one important element that you mentioned, I have since came across a gentleman who was in middle school with my daughter. And after talking to him, he had contemplated as well, at least a couple of her friends are contemplating suicide that they have told me. But this particular gentleman, what he brought out was, you're right. When we grew up, it was a different time period. It was a different shape of the community worldwide. And it didn't matter what part of the United States you came from. You know, there was a common theme there. But with this particular generation, the expectations of what we have accomplished in our lives, given the economic factors and what they see in society now, does not match up.
Right.
So it's actually harder, in some degree, devastating. You look at how many young adults still live at home, you know, which is a stigma sometimes within itself. Because
Right.
I'm now, and I think I remember my daughter saying, you know, what do you think about people seeing you two and I'm still living at home? You know, my response was always, I don't care if you live home until you're 50 years old or to 100. I just want to see you be able to stand up on your own 2 feet, you know,
Right.
and then we just go from there. Now, she had the luxury of having that. Some people don't have that. But what the
Right.
gentleman was telling me was that within that, that's even pressure too, because they're looking at their lives now and how can they compare
Right.
or to reach what we are when they're looking at what the reality is right now. And it's quite scary, to be honest.
Right.
You know,
And
it's one thing to preach education, which my daughter can see. We don't have to say it. She sees it, you know, in her mother and father. But look at the reality side,
right.
where you're supposed to get out and work and get a good job. Really, what does that look like? You
Right.
know, our jobs out there when you're hearing all the negativity. So, but yeah,
Yes,
it's just
that's
challenging.
very true. I appreciate you sharing that because, you know, the younger people, it's much harder for nowadays to be able to get jobs and, you know, to be able to get out there on their own and live on their own. And it's reassuring to have the comfort of your family. You know, even as a 60-year-old, there's times when I want to go back home and stay home.
Right, right,
To know that my parents are there for me, you know, that's a big support.
yeah.
So as I was listening to you, I wondered, where did you find comfort and support through this time when you and your wife went through this? Were there certain, like, you know, peers or church or friends, or who's been there for you? That's what I was curious about.
Um, First and foremost, when everything happened, when people start to leave later that day, if not the next day, I looked at my wife and I told her, whatever she thinks that we need, I do it. And I've always been opposed to talking to others. I always work things out for myself. But I just want to reassure her that I'm there. You know, I can understand as far as the loss that I'm feeling for as a father. There's no way I can comprehend the loss of a child from a mother's perspective. And I didn't want my wife to worry about me and how I would feel, that I'm there with you. And then from there, you know, we sought out the services that were available, where it was counseling. We still do therapy now, but we sat down and we made goals, you know, and I started coming up with phrases to help us get to the next thing, the next thing, and the next thing. And the very first one was, as a parent, I told my wife that we need to finish what we started. And that means that we're going to lay our daughter to rest, because it wasn't over. And so that kept us going to the next thing and to the next thing.
Mhm.
And then, like I said, then we sat down and we wrote our goals down, and we would look at them and we're going to, get to the next thing, get to the next thing. And we constantly, for example, at 9 p.m., we don't talk about what had happened and what's going on with our daughter. We turned it off so that we can try to get some type of rest, even though mentally we're there. We started giving ourselves little warning signs, like in sign language.
Mhm.
When you go like this, that's a T, but it's like a timeout for us. So if it's too emotional when we're talking, we do this, and it's out of respect for each other, not to say, okay, stop talking, but it's too much right now, and we can talk later. So we sort of have developed even more so as a unit to constantly figure out what is going to work for us,
Yeah.
and how can we stay together? Because we know statistically, it's not really good when a child is lost, parents go at each other, and it's not therapy that's really the help in a sense, which it is, but the work is when you're not in therapy.
Right.
It's when you're together. You go to therapy just to make sure sometimes you're on the right track, or get
Exactly.
another point of view,
Mhm.
from your thinking,
Objective.
and not to be there to argue and fight with each other. So that's our mindset, and we very positive and realistic. But we definitely had close people that has been knowing my daughter for over 20 odd years, and the people that I work with, and all the different associations that I'm part of.
Mhm.
That really surprised me as far as a support, because when I do things, I don't ask for a pat on the back or anything. I do it from the goodness of my heart, and for it to come together the way it did, it really surprised me. It really scared me, to be honest.
Mhm.
You know, uh, I never expected that, and
Yeah.
and I'm positive. So yeah,
Yeah. You guys are in such, that's a great uh reframing, I guess, in that you guys have so many skills, your wife and you have so many skills. And number two, you have a lot of acquaintances. And the reality is, a fair amount of the people you come across each day are struggling with depression in their family, which could
right,
potentially lead to this terrible outcome we call suicide.
right,
And and you're and then to tag along that, relationship is so important in getting a message out. Like, I can I can do an ad on television for Suicide Prevention Month, or I can do an ad about uh, this is your brain on drugs, or I can do a commercial about the dangers of smoking and lung cancer. But what's really going to be impactful is someone is giving your message to someone you know. You're gonna
yeah,
express your message in a heartfelt way, and and if it's someone you have good relationship with, they're going to be listening, and
right,
they might then begin to look at their youngster with Beck's triad in mind. Like, boy, sometimes I'm a little bit too harsh on my son. Sometimes I'm more punitive, but that might have worked for me 40 years ago, but the
right,
context is different today. There is so
correct,
much negativity out there today that maybe I need to reframe my discussion with my son, where I start off with the positive. I have to be true to
right,
myself. If they did something that I perceived as wrong, I have to be able to talk about it, but let me find a positive point to start out with, and
correct,
let
correct.
me end our discussion in a positive way. I'm just looking at
That's a good point. Yes, I agree with that, John. I just was going to say that what I hear in your story as well, Everett, is that you have a desire to help others who might be in similar
Yes,
situations.
yes.
yes,
And I know
yes,
here we have a funeral home actually that does a community outreach, and they invite like clergy and pastors and social workers and therapists annually to an event at the funeral home where they bring in speakers from the Pathway Center for Loss and Grief, and they
mhm,
brought family members who have been impacted by this. And those speakers were very powerful in sharing their journeys. as a way to help someone else.
Mhm.
And I see that in your story, that you would like to be able to help someone else. So I hope there's some organizations like that in Salinas that will offer, people have support through this time. I think that's very inspiring to other people, you know?
Yeah, thank you.
You're
Absolutely. And then,
welcome.
like I told your brother yesterday, this is meaning the suicide uh, avenue is one of my life purposes. A goal is to educate and be out there, hands down. And because I thoroughly love to help. I'm a product of the '60s,
Yeah.
and I say that you know it's my God's duty
Mhm.
because of all the benefits that I have been able to experience because of the ones who came before me. Um, and I've lived my life as such, and I'm going to continue doing that, even though my daughter is not physically here with me,
Mhm.
um,
Mhm.
because I would be unhappy, you know, and I
Mhm.
cannot be unhappy because then I may go down that spiral of that dark hole. And
Right.
I can't do that. I don't drink, I don't turn to drugs, I don't do none of that. My thing is to continue to develop my mind, ask for God's wisdom, and keep myself around positive people. And or I read a lot and I look for positive things. And like I said, I'm a realist, but I am an optimistic. And I ride with my emotional flow of things. When it hurts, I deal with it, but I come out of it and I go forward. That's the only way I know how, and
Yeah.
that's the way I'm going to keep doing it.
It kind of reminds me of, you seem to understand that saying about how service is our tax or our payment for having this gift of life. And I'm also going to say something that I don't think Judy knows in terms of your relationship potential is you're a Rotarian over here in the Monterey Peninsula, and that what an opportunity that could offer, right? I've been asked to be part of Rotary groups before, but it's a huge commitment, right? There's a great
It is.
there's a great payoff to being a Rotarian, but as I recall, it's a weekly commitment. True?
Yes, yes. It's a commitment for sure. Clubs have their own different culture.
Yeah,
You know, some are more stern, some are not. Some are fine based, some are not. Find the ones that fit your natural flow, your natural energy,
right.
the synergy. And I visit a lot of clubs, and some of the clubs, the synergy just wasn't there, but the one that I'm with, it was
Yeah.
just a perfect match. So
But and to build upon Judy's point is what a and I know you have a process that you and your wife have to go through, but you're poised with those kind of relationships that you've built over the years. You're poised to be quite effective in this whole suicide prevention mindset that we need to readjust to. That it is
yeah,
a preventable thing.
it
Um,
is.
so we're going to be turning the corner soon, and the last couple of questions I'm going to combine into one, and that is, why is this topic important? Please explain why it's important to HP's members. And is there anything that the members of the HP's community should be thinking about and activating ourselves about now?
Absolutely. It's important because it's life. Life is important. And as long as you're living, you have a choice. Some choices are challenging, some are not. But you need to, I guess, look at yourself and ask, am I happy or am I not? And if I'm not happy, what can I do about it? And all it takes is for you to believe in yourself and find others. And you determine how you want to live. Um, Unfortunately, because of what you mentioned earlier with all the different social medias, I remember telling my daughter when she was younger, and our symbol was this when she was in elementary school, and that means to think. Because, like I told her, the greatest challenge to her is not from your thoughts, it's really from other people's worlds and perspectives that you have to be able to discern what's real and what's not real, you know, and make those choices. It's the battle for your mind.
Hmm.
You have to be in control of your mind, and um, and that comes from being observant. It comes from reading and thinking, and it comes from relationships on how you sort of figure out this road that you want to be on, what brings you that happiness. So it's very important. Life is so fragile, and the
Hmm.
one thing I can say now, which is cliche, is that we hope we'll wake up tomorrow and this, that, and other.
Hmm.
Time is very precious,
Right.
because once it's gone, it's gone. And what are you
Right.
going to do with the time that you have? Because we all have that God-given talent, ability to affect change, not only within ourselves, but the people that is close to us or around us.
Yes, absolutely. Amen, actually. Um, Judy, are you still here? So my
Yes,
sister, my
I'm
s-
still here.
my
Yes.
sister, as we're rounding the final stretch, my sister has spoken to me about a program that she's familiar with in Pennsylvania called QPR, and it's in that model. Like Everett, I heard your wife talking about this is contagious, and I think this suicide prevention or suicide is contagious, and I think that the more we can take our suicide prevention work and build upon other models that other public health models that have been successful that the public already understands, I think will help promote this effort. And
Yes.
I'm going to let Judy, just a second longer, Judy. I'm going to let Judy talk about a model called QPR that she introduced me to. And basically, it's like taking suicide prevention and looking at it as if it's CPR, cardiopulmonary
Correct.
resuscitation. Are you familiar with
Correct.
that, Everett?
I am. I'm right now, and I am. I'm reading about it since you said it. Yes.
So let me do two
Yes.
Yes.
things. I am going to get to you, Judy, but Judy, there's a 1 minute video I'm going to try to show that
Okay, that's
that'll
fine.
that'll lay the platform for your experience.
Okay.
Okay, no problem.
Let me see if I can do it. After all that preamble, let's see if I can actually do it.
Yeah,
So
technology can be a
Absolutely.
challenge.
Yes. Yes. But thank you. This is awesome. Yeah.
let's see. It's quick.
So hopefully I answer your question too on the last part with the ACE members.
Yes, of course. That understanding our capabilities and urgency about health community matters. Community health matters.
Research shows that the odds of surviving a heart attack in a public place are 10 times greater in regions where thousands of ordinary citizens are trained in CPR. It's called bystander rescue. When someone shows signs of experiencing cardiac arrest, the response of nearby friends, family, or coworkers is critical. The effective use of CPR doubles or triples one's chances of surviving a heart attack. Like CPR, QPR is an emergency intervention for someone experiencing a life-threatening crisis. QPR is easy to learn and easy to remember, but it takes courage to overcome our fears about reaching out to help someone who may be considering suicide. Research also shows that where QPR is widely taught, suicide attempts and deaths decrease. Just like CPR, QPR requires quick, bold, and informed action. Because suicide, like heart attacks, remains a rare event, we must train hundreds to save one, thousands to save hundreds, and millions to save thousands. There is an old Welsh saying, no great misery goes unspoken. When we have a toothache, we tell people.
So yes, I wanted to offer that as an introduction to Judy to talk about her QPR experience. But you can see that everyone understands CPR pretty much in our society now. So I like the idea of piggybacking suicide prevention on something that society already is familiar with. So Judy?
Yes, yes. And I think mental health first aid is another kind of program that can help people with recognizing the signs and symptoms of mental health conditions, which suicides falls under. So that would be another program that I would recommend. You can probably access it. I know here in Pennsylvania, it was through our behavioral health, like the Department of Behavioral Health and Intellectual Disability Services. And then Also, maybe through the public health. I know that they train people in being mental first aid counselors, so to speak,
Mhm.
which will help them to lead other people in lead groups. I went through the training and they give you a lot of information, but they also give you a lot of role plays and interaction with each other. People who are on your team, they can bring the training to your organization. If you wanted it to bring it to your Rotary Club, or, it's really like a health awareness around how we may not be the therapists that give the treatment, but we can help direct people to where they need to go in order. So I think that's very important. The QPR is question, persuade, refer. So all we talked about earlier in terms of how difficult this topic may be to talk about, they kind of prepare you by, as another way, working with a team and a group of people who they train to think about some questions presenting to you who you think may be suicidal. Not again from a therapist perspective, but just from a peer person perspective. Then persuade that person, if they're open enough to talk about, what have they done in this situation and how might they be helped, to persuade them to get treatment. And then refer is similar to mental health first aid, referring that person to the people who can give the most help. Now, I know in Pennsylvania, they have crisis response centers that are often connected with the emergency department and the behavioral health. So often you might steer them that way. In the extreme case, like I was mentioning, this 302 process, which they might call it something else there, but if someone has decompensated very strongly, they can put the legal, process into effect that will automatically hospitalize a person. I don't know if there's any income, determinants in how they decide that, but sometimes the police are involved. Sometimes they use it with homeless people. They might use it with a lot of different populations, but I know there is a court-ordered legal process that you can initiate to get people to get help if the person isn't willing to get help, or if there's some circumstances that's preventing them from getting help. So that's kind of what I had to share in terms of, these two programs and what they do.
How
Well, thank
did
you. Definitely will.
Welcome.
how did
So I'll definitely be looking more into the QPR. So sorry, John, go ahead.
Oh no, so it's going to piggyback on your question, I think, is Judy, how did you have this opportunity come to you of QPR? Was it through your employment or was it through a civic organization?
Yes, it was through WellSpan Philhaven, which is our behavioral health department with WellSpan. That's how I got QPR, but I had it also training. I used to work as a recovery counselor / employment specialist in the city of Philadelphia. And so Commissioner Bernard Evans was then the commissioner for the the DBH IDS. And he has a very good video on transformation. If you look that up, it just gives a lot of vignettes about different people with different conditions in the mental health system and how they managed and coped with them. So when I was in Philadelphia, that's when I first came in contact with QPR, and that's when I first took it. I took it again here years later. But the mental health first aid, I also came in contact in both places, and I've taken it 2 times, I guess, because Philadelphia is different than Lancaster. But in essence, they train you to be people who can be a support. And I think they outreached to the faith-based community in Philadelphia. They might have presented it to the mayor's faith-based office so that the clergy, because clergy are often people that people turn to when they need help. And our clergy are not chaplains, so to speak, but they do minister to people in crisis. So I think that was the logic behind why they presented it to the mayor's faith-based community, so that they could also have this information and get trained in these topics, because, we go to our pastor often when we need support.
And I think that that is awesome, because another issue that society as a whole needs to look at is traditionally all you have is, when something happens, dial the 1-800 suicide, and that's really, to the extent, for most people, that's the only resource people know. you know.
Mm-hmm.
And it's really not about the 1-800. It's an extension, sure enough, but again, it's that relationship, having more people trained or just knowledgeable to have those warning signs they able to see and look out for, um, versus, well, we put it off on somebody else.
Right.
You know, it's always
And
a
then,
we. You know,
yes, and then also taking into context which community you're dealing with, because in some
right?
communities and people of color, we may not be as trustful of going to some of these resources, but I felt
No, yeah,
that yet these programs are very attuned to the cultural, spiritual, and community needs of different populations. And the people who were trained were from a variety of cultures and outlooks. So I think that's something that's also
right,
very important to look at when you're trying to, you know, decrease the stigma of it's not okay to reach out for mental health care or for, support around a lot of these topics. And there is a lot of work being done by NAMI, as you know, in their family to family groups. We also had, that available to us. But I think we've gone a long ways
correct,
to decrease the stigma associated with, all of these different topics that,
Mm-hmm.
this
correct.
happens to
And,
everyone,
and,
no
and you
matter,
touch on the
yes.
correct, and you touched on a big point. And I, get back to John. It's the trust factor.
Mm-hmm.
You know, as people of color, it's not only in the medical profession, and I see it in the education setting as well. You know, in the meetings, it's a sort of a us against them, or this is sort of not for me, which touches on the whole taboo. But what you're relating is really being educated and putting yourself out there and being involved. That's how I got to learn things and know things and be able to
Mm-hmm.
make better decisions. Same as my wife. A lot of us, meaning people of color, we don't do that, and or the opportunities probably not as there. And or there's a lot of roadblocks,
Mm-hmm.
when people are trying it and then they just like, okay, I'm done, I can't go anymore.
Mm-hmm.
So it's that pursuit, but we definitely need to continue to change the paradigm of the way people are seeing things.
So that's great. I know that our time is, I'm going to work to wrapping it up now because our time is really
Okay.
up against the
Oh,
wall. But are there any final comments you'd like to make for our team before I summarize today's discussion, Everett?
one of the big things that I would like to say, if all families, whatever you can provide or get, please get insurance on your kids, on your loved ones.
Mm-hmm.
And I'm not an insurance agent, I'm not selling insurance, but I can tell you from a personal, uh, my own personal, having insurance will help you get through the difficult challenge that lies ahead. And I say that because how many families have you seen when someone passed away suddenly, they try to raise money?
Oh,
Now, when you're sitting at the table, and for me, talking about my daughter in past tense, but at the same time, trying to, do funeral arrangement with the director, and you
right.
start seeing these numbers of cost of what it takes, because in your mind, you have an idea of how you want to lay your loved one to rest.
Mm-hmm.
But if you don't have those funds, that reality hits you that you can't do that.
I'm sorry, you lost me for a minute, but what an important practical point that you've made there. And people might say, "Oh, it's another expense," but in particular for a young person, the cost of life insurance isn't much at all. So, and then
No,
the earlier
it's
you
not.
get it, whatever your age,
Correct.
the less burdensome that cost could be.
Correct.
So I appreciate those comments. So in summary, I'd like to say that we made a lot of headway talking about this problem of suicide in our society today, how it's a rising or trending up concern for whatever reason, sadly so. And then we also talked about there are many levels of intervention. People talk about multi-level intervention. And what our discussion today focused more on the importance of relationship with people around us and kind of tools to be able to have those difficult discussions for people that are having spiritual or emotional, or rather emotional distress that could be a sign of depression or something worse. And it seems as though that whole effort is getting more organized through efforts like the effort of building up our skills to be able to help someone in distress, someone close to us, efforts like youth mental health first aid. Those opportunities are out there and available, including in our own Monterey County. And then Judy brought forward this idea of QPR, which is really suicide prevention CPR. And these are good and important things for us to know about and make us feel more useful in discussions with our friends who may be experiencing distress. And then finally, at the beginning of our discussion, we talked about at the policy level that there are barriers at the governmental health insurance level that there may be avenues for us to impact in terms of making things better for families that are experiencing these challenges with depression and trying to prevent suicide. So I think this discussion has been very helpful for our HP's audience. And I really would like to thank each of you for being available for this, and Everett in particular for sharing such an emotional topic. And I'm just so happy to see that the skills that you have intrapersonally that keep you going, and it's a lesson for us, and it's a lesson for my HP community, and just really happy what you're going to have to offer for the community as time goes on. I can see a lot of benefit coming from yourself, and I thank you for that.
Thank you. Thank you.
Yeah, you're welcome. And thank you, Judy, for helping with this presentation. And I look forward to continuing to work with you guys on future projects.
And thank you
And
for
the same.
that together, yes, and helping us to have these discussions. So we appreciate it.
Okay, so have a great rest of the weekend and keep
You
doing your great things. I'm very appreciative of that.
Okay,
Thank you. And you do the same.
bye-bye.
Enjoy.
Hope to meet you
Yes.
in person soon, Everett.
We can definitely make that happen for sure.
Okay, bye-bye now.
All right. Have a good one, sir. All right, bye.
You too, thank you.